Dr. Marie Pangestu, Managing Director of Development Policy and Partnerships at the World Bank, distinguished speakers, panelists, guest colleagues, ladies and gentlemen, a very good morning to all who have tuned in. The COVID-19 pandemic snuck up upon an unsuspecting world in January last year. Since then, healthcare and frontline workers have been fighting ceaselessly to contain the virus and its spread. As the virus continues to mutate, the surge in infections continues to rise and threatens to overwhelm healthcare systems. Each time any country thinks they have the situation under control, the virus surprises and outflanks them. Singapore is currently in the throes of this struggle. Despite one of the highest vaccination rates in the world, we have been seeing an average of over 3,000 new infections daily since opening up recently, with more deaths in the last 2 months than the preceding year and a half. Yesterday, Singapore's Ministry of Health reported 5,324 new COVID-19 infections, the first time the daily case number has breached the 5,000 mark. Yet, by all accounts, Singapore has done relatively well in dealing with COVID-19. Last year, we kept our population safe from infections using safe management measures as we waited for the COVID-19 vaccine to be launched. Once the vaccine was available, we lost no time in getting our population inoculated. Only when more than 80% of our population was vaccinated did Singapore start to open up. As of 26 October this year, 87.8% of the Singapore population have received at least one dose, and more than 700,000 people have signed up for their third dose. While the numbers of deaths have risen dramatically recently, Singapore's fatality rate from COVID-19 remains among the lowest in the world. However, not every nation has seen the same vaccine progress since the vaccines were released globally. The journey towards vaccine equity has been a bumpy one, fraught with manufacturing challenges, logistical hiccups, and revelations of vaccine hoarding. At a G20 meeting in September, the World Health Organization Director General pointed out that 10 countries have administered 75% of all vaccine doses, while low-income countries have inoculated barely 2% of their citizens. In the same month, WHO and sponsors of the COVAX program have announced that they will fall short of their vaccine distribution target to poor countries for this year by almost 30%. Eradicating vaccine inequity will go a long way to stop the virus from mutating and replicating in communities of unvaccinated people who are several times more vulnerable to severe disease and death. Countries, international health organizations, and healthcare networks need to translate conversations about vaccine distribution into actionable policies that strengthen vaccine access and encourage equitable distribution. This sentiment was echoed by Singapore's Prime Minister, Mr. Lee Hsien Loong, at the East Asia Summit yesterday, who said that for the world to bounce back from COVID-19, countries need to work together and towards equitable distribution of vaccines. Singapore has donated its COVAX allocation to other countries and its share of funds for vaccination under a resource pool to the ASEAN Secretariat and ASEAN members. To reflect our strong commitment towards addressing vaccine inequity, the National University of Singapore's Yong Loo School of Medicine is hosting the inaugural Asia-Pacific Immunisation Coalition webinar series. This series hopes to gather thought leaders from the Asia-Pacific region to discuss the benefits and opportunities of redistributing vaccine surplus in high-income countries to the low-income nations. In the coming weeks, we will have an exciting lineup of speakers who will be sharing their experiences of vaccine rollout in their respective countries and the urgent need to strive for vaccine equality throughout the world so that we can ready ourselves for the next pandemic. I would like to extend my deep appreciation to Dr. Tiki Pangestu and the organizing committee for setting up this webinar series, and to all the speakers who have generously given of their time and expertise to this webinar. I wish all our participants a fruitful session ahead. Thank you and stay safe.
Thank you very much, Professor Chong, for your welcoming remarks. Hello, everyone. Thank you for joining this inaugural Asia-Pacific Immunization Coalition policy dialogue webinars. So this is the first in our series of webinars. As you know, it's focused on optimizing vaccination in low resource settings. Perhaps allow me just to give you a little bit of context here. Most of you are aware of this. Basically, this is the global situation, as you can see very clearly, as Professor Chong mentioned, the huge inequities in terms of the number of vaccines that have been given in the high-income countries, the upper middle-income countries, as opposed to the low-middle income and the low-income countries. And the reality is that there has been little progress in vaccine equity. Only less than 1% of vaccines have gone to the low and middle income countries so far. As you may know, there's been a lot of talk about boosters. 36% of rich countries are boosting with a third dose, while 97% of people in low income countries lack their first shot. Okay, so in very broad terms, this is going to be the context of our webinar today. Before I introduce the speakers, let me end with a quote from Paul Farmer, which is basically summarizing all of this. If access to healthcare is considered a human right, who is considered human enough to have that right? Okay, so let us think about this absolutely fundamental issue of equity to access to vaccines, and obviously equity to health more broadly. Okay, so that's all I really want to say. Once again, to thank the very distinguished panel of speakers that have agreed to contribute today. So allow me to introduce our keynote speaker. Dr. Mari Pangestu is the World Bank Managing Director for Development Policy and Partnerships. Mari has a PhD in international economics. She was Minister of Trade of Indonesia from 2004 to 2011, and then Minister of Tourism and Creative Economy from 2011 to 2014. Last year, she was appointed as Managing Director for Development Policy and Partnerships at the World Bank. And as we all know, the World Bank has been a key international organization in trying to address this huge issue of inequities in vaccine access. So she will kick off our webinar by perhaps giving a global view, and then I will follow Mari and introduce our key speakers. So over to you, Mari.
Thank you, Kiki, and also thank you to Yapseng for inviting me to this. I believe this is the inaugural APIC, Asia-Pacific Immunization Policy Dialogue Series. So I'm very happy to participate in this inaugural series. By the way, APIC in, I guess it's Javanese, Pak Pandu can correct me, means beautiful, right? or good or nice. So it's a good acronym. So you're off to a good start. I've been asked to speak on the role of multilaterals in ensuring equitable access to vaccines, especially to the poorest countries. Let me start briefly with just adding to the context that Tiki already gave and what is relevant for the Asia-Pacific region and globally, obviously. Just two aspects. I think we talk about equitable access and about it being a human right. But for us, it's also not just about the right thing to do, but we know that the uneven recovery that we are seeing in the world economy right now is really widening the gap between advanced and developing countries. So 2/3 of developing countries will not reach per capita income back to their pre-pandemic levels before 2023. And lower middle income countries are even in a worse stage, probably not till 2024 or later will they reach their per capita income pre-pandemic. In East Asia, we know that the Delta variant and the kind of different rollouts of vaccines is also causing a slower recovery than had originally predicted. The consequences are poverty, increased inequality, setback in development, human capital scarring, and so on. So it's really both an economic issue as well as a huge development issue. Second, as was mentioned, access to vaccines remains highly unequal despite increasing supplies. So that's really, just to add to the numbers Tiki had, in high-income countries, 63.5% are already vaccinated. Upper middle income is 39.4%, with India at 20.9% and China at 72.6%. And they are manufacturing hubs. They have that higher result. In East Asia, of course, we have a variety of rollouts of vaccination. And the kind of if you try to understand which countries had more successful vaccination rates, one is if they are a manufacturing hub. Second, secured access to vaccines that they had been able to get early with a large diversified portfolio. Those who benefited from donations, and the government's central role in vaccine rollout. And we know that Africa and the lower income countries are far, far behind. Africa is at less than 5% of the population. So now let me now address how multilaterals such as the World Bank and cooperation between multilaterals and mechanisms that are now being created need to play a role to address the unequal and inequitable access to vaccines. To do so, you need a comprehensive approach. It's not just about a financing gap, but there are two other big issues, the supply issue and getting vaccines to people's arms. If you just look at the current multilateral cooperation around vaccine access, we have COVAX and ACTA, which is a multilateral coordination mechanism set up last year to respond to the pandemic. The idea was to secure for the population that most needed and for the poorest countries, so the ones that needed the most, the first 20%, and then for the poorest countries, it will be provided for free by undertaking advanced purchases of a portfolio of potential vaccines. Remember, they were created before any vaccines were approved, but they were not so successful because they were not able to get the doses because of the inability to secure contracts and options to purchase, lack of funding, and the fact that even secured supplies experience export restrictions, such as with Serum Institute, and vaccine nationalism in advanced countries. And then we have the G20 call for at least 40% by N21 and 70% by mid-22 recently, and the call for multilaterals to cooperate and pledges for donations. So we have the WHO, WTO, World Bank, and IMF setting up a multilateral leaders task force, or MLT, to take key actions to address the impediments in financing, trade bottlenecks, gaps in readiness and delivery, as well as manufacturing. And they now have also provided a website with a shared information set, because transparency and knowing what's going on is a big part of being able to address the issue. Let me now quickly go through the three aspects in a comprehensive approach that must happen if we are going to achieve vaccine access in an equitable way. First, financing gaps. The need is great. The majority of lower middle income countries and middle income countries even are not able to fully cover the cost of the vaccine rollout. And the World Bank has actually provided $12 billion and now $20 billion for financing of vaccines. And at the moment, we've dispersed $5.8 billion to 61 countries, 55% to the poorest countries, 41% to Africa, 19% to East Asia region as loans, IBRD loans. The others are concessionary or grants. And it's not just for purchasing, but also for deployment and strengthening the health systems. So if you look at 20 billion, why have you only dispersed 5.8 billion? We are being sort of being put to our task. Why are you not dispersing the financing quickly? The issue is not that we don't disperse quickly. There's a supplies constraint issue and the deployment and putting people's vaccines into people's arms, which I will talk about next. So in order to broaden the financing and reach, we have entered into partnerships. We have entered a partnership with COVAX so that we can support costs for shared doses with the COVAX AMC countries. This will give a greater financial assurance for COVAX and to negotiate and supply and expedite agreements. We hope this will increase the ability for COVAX to increase by a few 100 million doses. We've also undertaken regional cooperation with Africa, because Africa is only less than 5% of the population is vaccinated. There is the Africa Vaccine Acquisition Trust launched by the Africa Union to secure vaccine doses to complement COVAX. So we are working with that coordination, and already 40 plus African countries are in partnership with the bank to purchase doses, and we think we can provide up to 400 million doses. So second big issue, supply. Vaccine production is increasing, and it's expected that there will be 1.5 million doses produced per month, and it will continue to grow. It's mainly Pfizer and Oxford AstraZeneca leading in 2021, and then in 2022 you'll have mRNA vaccines as well as Sinopharm and Sinovac. We have seen a greater increase in vaccines, and there are also potential additional approved vaccines coming on stream. So one of the things that the Multilateral Leaders Task Force is doing is to streamline regulatory harmonization on approval of vaccines and support WHO EUL procedures to be able to have more vaccines on stream. But the problem is most Western-produced vaccines have been pre-purchased by OECD countries. And then we still have the problem of export restrictions from India, and we don't know when it will resume. So one of the MLT's actions is to advocate, encourage, push for the reduction of these trade restrictions and bottlenecks. But the main issue is still that you have increased supply, but a large share of this supply is not going to developing countries. It's not eligible to go to developing countries, whether or not through COVAX or through MDB financing. So what's needed? Donations and queue swapping for lower income countries via COVAX and AVAT. We are calling for advanced countries to deliver on their pledges for donations and release vaccines from contract options to lower income and middle income countries directly or through COVAX or through AVAT. If you want to know the pledge, the amount pledged is like 1.3 billion doses, with the US and the US accounting for 1 billion and EU for 500 million. But so far, we are tracking all this, trying to track all these pledges and whether they've been delivered. I think so far only 160 million doses have been fulfilled. So pushing for the fulfillment of the pledges, releasing doses and options to purchase quickly and transparently to LICs and MICs. Queue swapping, these are things that need to happen. And there needs to be greater transparency and coordination around the issues of vaccine supply, who is it contracted to, who is it, where is it being delivered to on the donations as well as on the contracts. And then there's also the effort to diversify production capacity, because 80% of vaccines is basically produced in Europe, US, China, and India. So how do you diversify regional production capacity, support local manufacturing capacity and skills in developing countries by, at least to begin with, invest in existing facilities? So IFC, which is the private sector arm of the World Bank, we have invested in Aspen, 600 million euro, together with the DFIs of France, Germany, and the US, to do filling and finishing and packaging capacity of J&J vaccines. And we hope that this will at least add another 400 million doses for Africa. So that's the supply side, still lots of issues that need to be dealt with. Finally, getting vaccines in people's arms. So this should not be underestimated. You know, we do a lot of work with countries. The World Bank, WHO, and UNICEF agreed on the template for vaccine readiness assessments, and we have been doing it since November last year in 140 countries to identify the gaps and assess the readiness to safely distribute vaccines. This includes, you know, evaluating whether there is a clear national vaccination plan, clear procurement policies, infrastructures, availability of trained health workers, communications and engagement strategy, because vaccine hesitancy is a big issue. There's huge challenges that coming up, even if you got the supplies, and it will come quickly, perhaps with more certainty. But the problem is you may not be ready. The countries may not be ready to be able to deliver these vaccines. So there's a huge issue here. So it's not just financing or supply, but also the readiness aspect. So we need to help countries establish policies for safe and effective deployment, put in place vaccine procurement and distribution systems, expand storage and building cold chains, develop tracking systems to make sure vaccines reach people, the right people, and training health workers and supporting citizen and community engagement. Just based on our readiness assessment of the 140 countries, the major gaps appear to be trained health workers and having the tracking system and community engagement. So, you know, this shouldn't be underestimated, especially in Africa. Vaccine hesitancy is very high. And so we are working with countries like we have a program in a couple of the African countries to work with community leaders, religious leaders, to have a community outreach and engagement to reduce the vaccine hesitancy. So out of our total financing, 5.8 billion that I mentioned, 63% is for vaccine purchase. And 37% is for deployment and other system strengthening. So you really need to have both sides, you know, not just procurement of the vaccine, but how to get vaccine into people's arms is really crucial. And so you do need a comprehensive, the multilaterals and in partnerships need to really move forward on all three fronts. Otherwise, you will not get equitable access to vaccines or the outcome that you want, you know, 40% by the end of this year and 60% by mid of next year. Just let me close with kind of some of the forward-looking issues, what we are calling prevention, protection, and response, PPR. That's the new acronym that is being talked about for all crises. But in the case of pandemic, there was a G20 high-level panel that made a recommendation that you need new funding, a new pool of funding, and new governing mechanisms, because it seems that, you know, if you listen to what I explained to you, there's a lot of misses in there, and there's a lack of coordination and an ability to move quickly and respond with very dire circumstances. So this is the big G20 topic between health and finance ministers. I don't know where they're going to land in a few days' time, but our view is that what we need to do is just start with identifying the gaps, whether it's the mechanism gap, the financing gap, the instrument gap, and just be clear on what you need to do. What do you mean by prevention and preparedness to be able to understand all these gaps? So we think that you don't need to necessarily create new institutions, but you can certainly strengthen and improve the coordination of the current mechanisms. And if you had a new pool of funding, is it better to go through the existing mechanisms, or do you want to totally create a new institution and a new to deliver this new funding? These are some of the governance issues moving ahead on the multilateral front. So it will be in the Indonesia year of G20 that these issues will be further discussed. And you will, because you are in the East Asia, Asia Pacific region, I think you all should also contribute to this discussion. Let me close there. I think I have exceeded by a few seconds, but I hope that you have found what I have shared with you useful for your discussion, your subsequent discussions in this panel. Thank you very much.
Thank you very much, Marie, for that very up-to-date and succinct overview of the importance of multilateralism and the role of the international organizations. I like your call at the end for PPR, prevention, protection, and response. Obviously, we know about the calls for a new governance. That's perhaps something we can revisit. So now for the second part of the webinar, we would like to actually hear from the countries in the Asia Pacific region. What are, what's the current situation in your countries? How are you facing this issue of inequity? And what are your governments and communities doing about overcoming these inequity issues? So it's my great pleasure to introduce my old friend Lulu. Lulu Bravo is a professor of pediatric, infectious, and tropical diseases at the College of Medicine at the University of the Philippines. She is a leading authority in the region on the topic of infectious diseases. And I have had the pleasure of knowing Lulu for many, many years over many, many issues around infectious diseases. She is the president of the Immunization Partners in Asia Pacific and the current executive director and past president of the International Society of Tropical Pediatrics. So Lulu, over to you to give us a view from the Philippines.
Thank you very much, Dr. Tiki and Dr. Marie Pangestu. It's really amazing how we can all be able to collaborate, coordinate, cooperate. And thank you, National University of Singapore, for actually having to initiate this first APIC, Asia Pacific Coalition, Immunization Coalition. I think it is very timely. And today, I am really very conscious that we all would like to see what is going on in the Philippines today. The Philippines has been having 3 surges since last year, as you can see, all those from the January 2020, and we are now at the peak since August, but slowly we are going down the ladder. And as you can see, this is from January to actually 2020 to October. This is the death rate on the below the chart, and this is for the different regions, NCR, Luzon, Visayas, and Mindanao. Next slide, please. You can see that actually we have 56 million doses administered right now with 26, almost 26% of the 110 million population that we have already. And about 30,000 are still partially, 26 fully, 26 million. And as you can see from the graph, this is the first one, the yellow one with the partial and the fully vaccinated is close to 29%. Next slide, please. You can see that this is much improved from our September 1 month ago of 37 million doses. So over a 1 month period, we have increased 20 million doses. Next slide. And that was the promise of the government, that in fact, we will have at least 20 to 30 million doses a month until the end of the year. And true enough, we have seen how this has been moving on. The procurement, can you see? We did have additional financing thanks to World Bank, ADB, which was sought for the country to enable affordable and equitable access to COVID-19 vaccines and help ensure effective vaccine deployment in the country through an enhanced vaccination system and to further strengthen preparedness and response activities. As you can see, the most number is from Sinovac, mostly procured, but then there was a donation of about from China. And from Pfizer, we did have COVAX and some procured. For AstraZeneca, we did have some donation by the Japan. And of course, even Moderna and J&J did have some donation from China also. Next slide, please. But you can see this is the pie chart. Now, aside from financing and funding, we do have another barrier to our vaccine kind of deployment, and that is vaccine hesitancy. You know, just recently we have been announced that registration, and it has started pediatric vaccination from 12 to 17, just about a week ago. But you can see the announcements are made on a political kind of maneuverings. Well, it is political season now in the Philippines. And as you know, the political situation has really kind of produced some kind of barrier to really improving vaccine hesitancy. Next slide. If you remember that in 2018, we had a very massive disaster with the dengue vaccine fiasco, where people started to think vaccine can kill. This was the effect of the Sanofi announcement that, in fact, there could be a more severe dengue in those who have not had previous infection. And mothers thought that those who had serious illnesses after vaccination with dengue vaccine, would have SLEs, leukemia, would be even dying. Next slide. And this actually has led to a very much decrease in vaccine confidence in the Philippines, from a high of 93% confidence in 2015 down to 32% in 2018. And amidst this controversy and complacency, we have inevitably a return of the vaccine preventable diseases. Measles, 600 deaths in 2019 because mothers refused to have their children vaccinated. And this was even before the pandemic. How could you now try to overcome this barrier? Next slide. And this is where we come in with the pandemic. And this is where we have to really trust government. You know, there is always this inherent trust in government when we will have policy making, and that was enhanced by the dengue vaccine. So now come the pandemic. And the silver lining here is that a lot of people cooperated, you know, the experts who were called to, you know, bring about the recommendations official and bring the support they need for the Department of Health. So the Department of Health started to go the pre-implementation activities and using science, actually, for the vaccine expert panel, the health technical assessment committee, there was the technical advisory group, the NITAG, forming almost overnight. But of course, we don't lack experts, by the way, in the Philippines, but we need to have the support. And the government especially made this happen. They identified scientifically what needs to be selected from among those that are being done. But as you know, we do have limited supply, and somehow we have donations from COVAX, and a lot of people were really arguing. But somehow we were able to do identification, master listing, screening registration, vaccine allocation, distribution. And then once the vaccination started, we did have implementation activities that would go for post-authorization surveillance. Next slide, please. As you can see, vaccine administration were actually rolled out in a way that was transparent. In fact, every day, the Department of Health would give out communication, would be on national television, giving all the announcement, what is the next, the priority that will be given. Next slide. You will see that we did have, next slide, distribution, how it will be done, prioritization for vaccination, and A1 are the frontliners, A2 senior citizens, A3 are those with comorbidities, and the indigent population, A5, and down the line you have the group Bs. So all of them were actually prioritized. Next slide, so that we will be able to actually come up with a good flow chart and even adverse event following immunization. And I am proud to say I have been part and a chair of the NAFIC, National Adverse Event Following Immunization, to really look at the reports. Next slide, please. And you can see that aside from this, we still have those certainties that we have to look after. Because truth to tell, there are so many questions. Should we actually be able to reach the herd protection? Should we have answers only through vaccination? Should we use the inactivated vaccine more readily, because there are always questions about the Chinese vaccines versus the Western vaccines? But of course, the communication is there. Next slide. And I really talk to our SAGE member, Kim Mulholland, for all this, because the challenges are there. Adverse event causing vaccine hesitancy, the variants, the uncertainties, and of course, how to really do communication and advocacy. Next slide. And we can see that, in fact, the path towards the success of the COVID vaccine is really dependent on vaccine confidence. And this is where you will now have to talk about, get the messengers, the experts to say that you have those simple, clear messages. Vaccines are safe, vaccines are effective, vaccines work. And we should all work together to develop this plan and even engage media to be able to do this. Next slide. We are battling vaccine confidence because it cannot just be increased by facts and education alone, just like what Dr. Tiki said. Next slide. You do have to fight infodemics, misinformation, disinformation. And this is something that is not just being given by facts. You have to really do it with a lot of community involvement. Next slide. And therefore, we need the experts to be involved who will respond with transparency, empathy, equity, equality, timeliness, honesty, and of course, confidence. And we can look for our former health officials to be able to be there with us. So thank you very much. I hope I had been able to give you what the Philippines has been experiencing so far.
Thank you very much, Lulu, for that very nice summary of the situation in the Philippines. And I'm heartened to see that the Philippine government has shown considerable political will and commitment, resulting in wonderful progress just in a period over a month. So thank you very much for that. So it's my great pleasure now to introduce our second speaker, Dr. Gagandeep Kang, who is professor at the Wellcome Trust Research Laboratory Division of Gastrointestinal Sciences at the Christian Medical College in Vellore, in India. She has the wonderful distinction of being the first woman from India to be elected a Fellow of the Royal Society. That's really a wonderful achievement. She's also the first Indian woman to be elected to Fellowship of the American Academy of Microbiology. So it's really an honor for us to have you join us, Dr. Kang. And obviously, India has had some really severe experiences with COVID. Situation seems to be improving. So we really look forward to hearing from you in the context of what's happening at the moment in terms of access to vaccines. Mari already referred to the export bans. As we know, the Serum Institute of India is the biggest vaccine manufacturer in the world. So very much looking forward to hearing your views on the situation in India. So welcome, Dr. Kang, over to you.
Thank you very much for the invitation to speak to you today. I'm going to be talking about what's happening in India and in terms of access and delivery, how we're doing. So if we look at vaccines that are accessible in India today, there are basically 3 vaccines. One is Covishield, which is the AstraZeneca vaccine. The other is Covaxin, an inactivated vaccine made in India. And Sputnik V, which is a vaccine where the doses are currently still being imported from Russia. But there are multiple companies in India that are trying to make this vaccine. And this is a vaccine that has 2 different adenovirus vectors, AD26 and AD5. and there seems to be a bit of a struggle with making the second dose of the vaccine. So lots of the first dose can be made, but there's a challenge with the second dose. So Sputnik and its collaborators are trying to see whether they can make Sputnik Light, which is a single dose adenovirus vectored vaccine. Now, with COVID, maximum production in India is of Covishield. It's about 88% of all the vaccine that has been used in India so far. Covaxin is an inactivated vaccine, and that is about 11.5% of the vaccine that has been used in India, and Sputnik V is maybe about 0.1, 0.2%. Now, Covishield production in India is over 200 million doses a month. Covaxin is trying to increase its production, but hasn't really gotten very high. We've been running at 10 million doses a month, or increasing slightly. There are now there was one facility we started with, and it has been possible to approve batches from a second facility. The goal of the government is to have 6 different facilities that will by 2022 be making doses of Covaxin, and they're aiming at 100 million doses. With Sputnik V, I'm not sure where it's going. The goal was to have 100 million doses a month, but with the current struggles that the companies are having, we'll have to wait and see how that plays out. We also have another vaccine that has been through phase 3 trials. This is the Zydus Cadila DNA vaccine. This can make only small doses at this time. It's between 5 and 10 million doses a month, but the goal is to be able to ramp this up, and they are looking for partners to help do that. There are every single platform of vaccines that is available in the world is being tried in India. This includes subunit vaccines with the receptor binding domain. There is also the Novavax vaccine, which is being produced by the Serum Institute of India. There is an mRNA candidate from Genova. This is in phase 3 trials at the moment. There are other adenovirus vectored vaccines, and there are attempts to make live attenuated and nasal vaccines as well. So many of these are now in clinical trials or getting ready for clinical trials. The furthest along are the biologically receptor binding domain with the CpG adjuvant, which can make 1 billion doses a year. So in terms of production capacity, if the phase 3 results of BioE are successful, we will have a lot of vaccine available for the world. Genova is setting up its own manufacturing facility and is looking for partners to help manufacture more doses of the mRNA vaccine. And the Novavax vaccine with Serum Institute of India, there is huge capacity at Serum Institute to produce this vaccine. The problem is that Novavax has been struggling in terms of regulatory approvals in other parts of the world. So this is a complicated situation at the moment. The J&J vaccine, which is being made by BioE as a contract manufacturing organization, is also capable of making large volumes of vaccine. But there needs to be an understanding on the regulatory process and the export process for this vaccine, which is still under discussion with the Indian regulatory authorities. It's unlikely that the Indian government will buy J&J vaccines, so this may be a great opportunity also for India to be able to provide vaccines to the world. Now, where we are with vaccination in India, about 75% of the adult population has received at least 1 dose of the vaccine, and over 30% of the adult population has received 2 doses of the vaccine. If we look at the daily numbers of vaccines that are being administered in India, it's somewhere between 4 and 5 million doses a day. We have reached 25 million doses a day being given, but that was really an odd event to celebrate the Prime Minister's birthday. So somewhere around 5 million doses a day is a reasonable estimate of how we are doing right now. And I hope that we will continue to do that for the future. We've given out over 1 billion doses of vaccine. And as I mentioned, coverage is about 75% for a single dose. This has to be placed in context of a survey that was done nationwide that showed that in June and July of 2021, about 67% of the country was already seropositive. That was at a stage where vaccine coverage was much lower. And it just goes to show the devastating impact of the second wave that was driven by the Delta variant through March, April, and May of this year in India. We are down now to under 20,000 cases a day being reported. That is from a peak of over 400,000 cases a day. Now, this is a platform that was developed in India, which is the convenes platform. It's a platform for registering for vaccination, and it tracks on a real-time basis what is happening with vaccines in the country. We have over 70,000 sites that conduct vaccination. Only about 2,000 of those are in the private sector. The private sector is entitled to buy 25% of doses, but actually takes about 7%, and government facilities deliver the rest of the vaccine. So we are at 1.04 billion doses as of last night. What are the issues being discussed in India today? Vaccine hesitancy isn't a huge deal now. Access to vaccines and the ability to deliver vaccines at scale to remote populations, I think, is going to be a challenge. But there are lots of questions that people are discussing about which vaccines to use. So far, we have no imported vaccines. We have only the indigenous vaccines. And then there are, of course, all the questions that everyone asks about children, about boosters, about dosing intervals. And then, as Lulu highlighted, the side effects of vaccines and our ability to monitor them at the level that new vaccines should really be monitored. So I will stop there. Thank you for your attention.
Thank you very much, Dr. Kang, for that wonderful overview. I am particularly struck by the important role that India can play in the future in terms of being a major donor of vaccines, as well as the potential capacity for a domestic production. I think in the future, perhaps one of the key strategies for overcoming vaccine inequity is actually South-South cooperation, cooperation between lower and lower middle income and upper middle income countries to together overcome this issue that we are very concerned about. It is now my great pleasure to introduce Dr. Pandu Riono, who is from my home country of Indonesia. Dr. Pandu is an epidemiologist at the University of Indonesia at the Faculty of Public Health. He is a leading authority and leading advocate for key dimensions of data information, and a very strong advocate for the various measures that are needed to overcome the COVID pandemic in Indonesia. I have relied a lot on Dr. Pandu for data and information from Indonesia. There's probably no better person, in my view, to give us sort of an up-to-date view on the situation in Indonesia with respect to vaccination and vaccine access generally. So terima kasih Pak Pandu. Over to you now.
Thank you, Professor Tiki, and good morning, everybody. And thank you for good remarks from you, Professor Tiki. It's okay. I will present the presentation. Vaccine access and delivery in Indonesia is not easy because we don't have a manufacturing vaccine in like India or another country. And our population is very big. You know that it's very difficult how we should prioritize, how we should strategize about the vaccination is the part of how we control the pandemic in Indonesia. And currently in Indonesia have good conditions because most of the cases is already going down, and we have in the low level now. And we have during July, the peak of pandemic is very high because of Delta variants, and also the mobilization because of Idul Fitri. People go to their home country and their hometowns, and mean that make the Delta variant spread faster during that period. It means that during June, and then we can see the speed up of the cases, and also the death, and also the people who got severe, and the hospital around the country already collapsed, and many people cannot get received by government. The hospital cannot taking care of any COVID, severe COVID that already become all the country. It means that not only in the big city like in Jakarta, but most in Java, Bali Islands. And we are doing the first time Delta variant is wake up our governments to do the populations, the restrictions, national restriction. This is the first time the government's trying to do. Before it's just some small or just part of the country like in province, but that now doesn't work because the spreads always happen, and many the mobilization still maintaining the spread of the infections to all the country in Indonesia. And by doing the coordinations, with government, the Delta, I'm happy with the Delta because government finally accept that they should control centrally, not by let the centralizations to control the pandemic. And also Jakarta is the epicenter for pandemic that currently we had 0.1 cases in the first week of October. It means that when I led the governor of Jakarta during September, that I said that Jakarta will get the zero death the end of September or the first week of October. He didn't believe that, but actually happened. Why it happened? Because currently we always using the data to make predictions, to monitoring, and this is a good data that can be validated that our predictions. And Indonesia is currently that we can see the reproductive already got the less than 1. It means that the low transmission. This is the 10 October. Maybe currently already 0.9, that hopefully we can maintaining these low transmissions, the low cases is happen all the country, not only in Java, but all the countries. And we are afraid, actually, the government afraid of the transmission, the third wave of pandemic. We are afraid of the emerging, the new variants, the new Delta, the Delta plus. And we still have problem with the vaccine equity. And we only 100 million people from Indonesia that less than 50% that already vaccinated in the first injections. And the problem is about the next December, before December, we have a holiday, a Christmas holiday, New Year holiday. Mostly the people will go out and they will mobile to go like in Idul Fitri, their hometown, and maybe go to some area that for tourists or for entertainment. That's the social mixes is the part of the contributor of the second wave. The big second wave is because the social mixing before Idul Fitri, and using masks and keep social distancing is very difficult, and it means that we cannot rely on the behavior of people because they're very, very inconsistent. And also we had the problem with the misinformations regarding the pandemic and regarding the vaccinations that still can be counterproductive when we want to maintaining the situations or controlling the pandemic, controlling the transmission in Indonesia. This is we realized, and the government realized how we should dealing all this to prevent the third pandemic that will be predict that will become in the first months of January 2022. But actually we can prevent it because currently the problem is different. Okay, this is the intervention that the government adopt using infection risk and promoting the using masks and physical distancing, and also speed up the test, tracing, and isolations. And when we restrict the movement of people, we can control the transmission. But currently we lose the restrictions, and then we are maintaining the situations by keep up the vaccinations. It means that we want to vaccinate all people in Indonesia, because our objective is not how much the vaccinations, but we should achieve of the immunity level in the populations. Not only the vaccinations, but actually already some people in Indonesia already got the infections. It means they got the natural infections, the natural immunity. And we are trying to advocate the governments that about the concept of population immunity, because they are always dealing with the herd immunity, and the problem is the herd immunity is very difficult for COVID-19. And we are trying to make many people, like in Jakarta, already almost 50% of people already infected during our survey in March, before the vaccinations to the people already delivered, but still focus on the health worker and the public servants. It means that some people already infected and survived. And that's the immunity that we got the natural. And many, only 10% that in Jakarta already infected, but find out in the testing. This is the situations. And we can see the vaccinations is also get the immunity. And here, we had a lot of, because the infected people already become very high, and then we can have the vaccination maybe still low. We get some people got the both of the immunity. It means that maybe got super immunity. I don't know what's called it like this. And this is the Carta, and then we can see in March only 50%, and June become increasing, and during the Delta variants become double incidence, and this is we can see how much the people already got immunity. Okay, and hopefully that if people got the immunity, it means that we can get the problem. And we focus on the not only city but also agglomeration area. This is the way we monitoring the community, the vaccinations coverage. In Jakarta already more than 90%, but surrounding Jakarta still have problem. This is not safe for Jakarta if they cannot helping the surrounding area to get the vaccinations like this. Okay, at the same. And how we prioritize? The prioritize for the vaccinations, because we don't have enough vaccine, we focus on the agglomeration area. Maybe 9 or 10 agglomeration like in Jakarta, surrounding area, in Surabaya, in Makassar, in Medan, in some area, because the epidemic is happen in that area, not all the country. And then we focus on the vulnerable population, especially people with comorbidity and aging people. This is the focus. And then how we are dealing the vaccinations. We are dealing the vaccinations is by monitoring the difficult part to distribute to all the country. Every day we monitoring, we come and we receive the vaccine from some country, from donations that then only between 1 day and 2 days we should distribute, and then we monitoring and by real time, and then we distribute all the country. It means that we can see how the efficiency, because the in some area maybe they already received but not delivered to the people. It means that we should help because we don't want the expired the vaccination, because most of the vaccination is the duration of effectivity is very short. And now we can move to endemic phase, because we got the suppressions, and now we stabilize until next year, and hopefully in the next year we can normalize. It means that we can maintaining the low transmissions. Thank you.
Thank you very much, Pak Pandu. And as an Indonesian, I'm happy to hear that the situation seems to be improving compared to 3-4 months ago. But of course, the worry is that we are still only 50% of the population receiving the first dose. So thank you to all the speakers. We now have a little bit of time, maybe just on half an hour for Q&A. So please, those of you who are participating, should you have any question, please post it on the Q&A, and I will sort of try to address the questions to the various panelists to try and respond. Perhaps while we wait for some questions, let me perhaps begin by asking Dr. Kang. I was struck by the contrast that you mentioned, that vaccine hesitancy and misinformation did not appear to be a major issue in India. Okay, forgive me if I got that wrong, but sort of that's perhaps in a contrast to what Lulu said before, and perhaps Pandu also mentioned. So, Dr. Kang, do you have any views why and perhaps how the Indian government, why is there not such a big problem with hesitancy in India? Is it because the government has taken steps to overcome that particular issue, which obviously is a big challenge moving forward? So over to you for your views on vaccine hesitancy in India, Dr. Khan.
Thank you very much for the question, Prof. Tiki. I think the government, along with immunization partners, started preparing for communications very early. There's a beautiful document that's available on the Ministry of Health website, which is about 88 pages on how to communicate, how messages should be structured, what the key stakeholders are, and how to address issues that might arise. Now, where we are currently is that in the initial phases, we actually saw a lot of vaccine eagerness, people wanting to be vaccinated and engaging in practices that were unethical in order to be able to book vaccination slots. Now, that pressure of vaccine eagerness has eased. What we are seeing mostly is a very small fraction with vaccine hesitancy, and these tend to be more the educated urban populations that are influenced by American anti-vaxxers. And in rural areas, it's mostly around the fact that people don't know about vaccines. As soon as we have structures in place for communicating to them through their community leaders, there is an acceptance of vaccines. So whether it is tribal communities, whether it is remote locations, it's really been who is communicating and at what time that leads to increased vaccine uptake. As we get beyond 75%, it is of course possible that we will now come up against pockets of people who will refuse vaccination. But we are nowhere like the kind of situation where we have lots of people refusing vaccines.
Okay, well, thank you so much for that. I think there's probably some learnings there, but I believe your emphasis was on, the government having a good communication strategy, and as Lulu highlighted, it's about the right messages and about the right messengers. Okay, I'm just looking at some questions here. Mari, are you still online?
Yes.
Mari, are you online? Okay. So some questions for you. The first question is, what defines a low resource setting? Now, we know very well that the World Bank have this sort of classifications of low, middle income, etc., etc. So what defines a low resource setting? And the second part of the question is, what should high income countries do or not do to truly address vaccine inequities? So I hope you're still awake. If you can just try to address those two. Over to you.
Yeah, I mean, when we say low resource, we mean the poorest countries, which is what we call, in the World Bank has IDA and IBRD pots of funding. So when you talk about IDA countries, these are the poorest countries. And, you have the income levels and other measurements like vulnerability and fragility and conflict. And for those low resource settings, we provide grants or very, very low interest rate or concessional lending. So that's how we would define it. And obviously COVAX provides for free the first 20% of vaccines to these countries. So Indonesia is actually one of the 92 AMC countries. So Indonesia did receive 20%. I don't know, maybe not yet 20%, but is going to receive from COVAX. And when you talk about the middle and higher income countries, what we are doing is providing loans, IBRD loans. But for middle income countries, actually what they appreciate more is not so much the financing, but you must look at the bank not just as giving financing. We have what we do well because of our experience over many years dealing with health issues is actually the advice and the diagnostics and the tools that we can help countries with to design the deployment program, to work with them to, at the same time that we are working with them to put a vaccine in people's arms, we're also strengthening the health system at the same time. So, it's a short-term as well as a medium-term objective, and then the training of the workers and so on. So we can come in and help support the design, the assessment, the needs, the design of the system, with the hope that, it strengthens the health system overall so that it strengthens your ability to prepare. Prevention is another set of issues that we have to deal with, but prevention is also equally important. We do the same, obviously, with the low-income countries, but for medium-income countries, I would think that is what they appreciate of the bank also.
Okay, thank you, Mari, for staying up so late. The next question is to Pak Pandu. Okay, I think we're very fortunate in this webinar to have represented the second and the fourth largest countries in the world. So, Pak Pandu, the question to you is, what basically is the reason for Indonesia being successful in sort of controlling the pandemic? As you mentioned, the situation is now quite good. And is it public health restrictions, despite also the fairly low vaccination rate? So what's your view on this particular question? What's the reason for Indonesia being successful so far?
Okay, this is not successfully permanently. Yeah? Maybe the situation is still uncertainty, but temporarily, yes, we got success to reducing the transmissions. It means that we got the hospital already empty. There's no cases, severe cases, maybe only 2 or 5, and we got a lot of now currently very low death in all the country. It means that what the explanation? The explanation is this is the first time governments make national very strong restrictions to nationally, and we divide by Java Bali, the biggest populated area, and then non-Java Bali, outside Java Bali. And the second, for vaccination, we prioritize to focus to the agglomerations area. It means that not distribute all the country, but where the city and some surrounding people living in the city, the big city, we spreads. It means that we delivers more the vaccine. And the third is we prioritize the people who vulnerable, like old people, aging people. And by those combinations, I mean that we are too late. I explained that currently the immunity in some area in Indonesia, like in Jakarta, before it's already 50% get natural immunity, and then 90% or 80% in Jakarta got the vaccinations. It meant that they got strong immunity that for the Delta variant, whatever the vaccines, the vaccination types, Sinovac, Moderna or Pfizer or AstraZeneca, it doesn't matter. They provide more protections. It means that based on these situations, I believe this is contribute to overcome, to dealing with the faster reducing the cases and maintaining in some level. But this is very difficult maintaining because the Delta is still there. The Delta variant is still dominating the country. It means that if we got a new Delta, a new variants, I don't know, this is still work or not. But that's why we currently to speed up the vaccinations all the country, and we are trying at the end of this year, more than 50% people in Indonesia already got the second injections. That's the explanations of the success story in Indonesia.
Thank you very much, Pak Pandu. And I've been sort of impressed by your answer that it really is a combination of pretty strict public health restrictions plus monitoring, plus obviously the continued drive for vaccination. Lulu, let me turn to you. I hope this is not too controversial, and I think Dr. Kang had already alluded to this as well. You mentioned that within the Philippines during the crisis and the response to the pandemic, there were some political aspects, okay? And I think we all agree that in all our countries in this part of the world, that is always in the background. So would you be able to elaborate a little bit what you mean by sort of political influences within the overall response to COVID and how important that is in the Philippines and your views generally on this?
Yes, thank you very much, Tiki. This is really what has been going on. You know, way back in 1990s, when we had the Senator Flavier, vaccination is always at the forefront of our health policies and health delivery system. In fact, we did have almost 101% vaccine confidence. We would give a national immunization month every year for 4 years, giving millions of doses as catch-up. Then we started to be more complacent because measles was disappearing and everything that is really glorious. Then came Yolanda and the disasters that decreased vaccination coverage in 2013. But lo and behold, the one that really dealt a big blow to our vaccine confidence was really the politicalization of the dengue vaccine issue in 2018. Because of the fact that mothers really refused. Imagine, from a high of almost 90% coverage, we went down to 60 in 2020 actually, but in 2019 it was also down to less than 50%. So miserably, we had a reappearance of measles and polio. And this was because they realized that the vaccine can be used as against a kind of political tool to go against the previous administration, because they gave the vaccine, the dengue vaccine, during the time of election. And so this is not really new. I think some other countries like Mongolia had also that experience. But then they realize now that, in fact, vaccines can be made a tool either positively or negatively. And even now we can see the politicalization of COVID, because some people believe that those regions that are receiving more vaccines are the ones that are favored. Okay, that is not my opinion. That's the opinion in social media. That's the opinion in newspapers. And this is really getting to be a little bit sometimes devastating, because we know we want science. We want to be equitably distributing this. But somehow some political analysts would say, okay, there are people that are getting more vaccines because they are pro-government, pro-administration. And then you can see the one picture that I showed where even the presidential candidate, because it's now political season again in the Philippines. We will soon be electing a new president by 2022, May of 2022. And there is now 5 candidates for presidential. And I'm really fearing that somehow with the onslaught of the pandemic, of course, just like Indonesia, and I envy Indonesia because they had much earlier, the drop in the peak of Delta variant. We did experience that. And we are now from a high of 26,000 cases way back in August of this year. We are down to just about 5,000 new cases every year now. I mean, every day. So this is something that we like. But again, the distribution of vaccine is the one that is kind of difficult to say at the moment, because we are hearing that the government is really trying its best to engage the experts, and we are having like almost 100 experts every time we meet regularly to discuss. These are the NITAG, the Technical Advisory Group. We have a vaccine expert panel. We have the NAFIC. I'm part of the NAFIC, the adverse events. And of course, we do have the health technical assessments. So many people are really meeting every week to try to give an official recommendation and to try to make sure that, science, as you said, Tiki, the Philippines has long suffered from science illiteracy. I guess some of our policymakers really need to be educated much. Not the health officials, mostly those who are in Congress who really use, science kind of, overcoming science. And politicalization is what is going on. But I do hope that we will have some solutions to this. I think I'm just praying and hoping that soon enough. With your help too, APIC would help us.
Thank you very much, Lulu, for those views. And I think we all realize that politics is part and parcel of health, as you highlighted. All three countries, Indonesia is facing general election in 2024. The Philippines is right in the middle of it, and so is India. And I believe certainly that the highest level political leadership is absolutely critical moving forward. And, any leadership transition is potentially going to affect this. But, in a sense, I do have sympathies with policymakers because they are having to make decisions in a situation which is rapidly changing. The science is moving all the time. And I remember in Indonesia, some of the policies, the tight restrictions was very unpopular with the general public. And, there's a saying that what is popular is not always right, and what is right is not always popular. When I was working with WHO, with policymakers, I can understand that, they make decisions not just based on the science. Of course, they want to follow the science, but they have so many other issues to deal with, and in a situation where the science is changing all the time, where the experts even disagree, I do have sympathy with them. So thank you for all of those contributions. Perhaps one last question before we wrap up. Maybe to Pandu and reflecting what Dr. Kang had mentioned about sort of the importance of perhaps domestic production capacity. Pandu, what is your view of biopharma, for example, which we know has always been one of the sort of regional models for quality vaccine production? Do you foresee biopharma being an important player, perhaps in the region, especially in the ASEAN region, together with India? Do you foresee that they will be playing a more important role in the future to overcome inequity? So a short opinion from you on biopharma.
Okay, thank you, Professor Tiki. That's right, that biopharma are actually already manufacture some vaccines like polio and I don't know, many that already export to another country. It means that biopharma already have some capacity. But when we promote we should have some manufacture vaccine in the country, it's difficult because they believe that if they want to develop the vaccine, it should be from zero. It means that Indonesia spend most of the money and time to develop Indonesian vaccine they produced by our country. This is not in the right situation when we got the emergency. Our emergency situation is should have the vaccine already approved benefit and already approved the safety, and then produce right away as far as we could, because not get benefit for our country, the biggest populations in the region, but also can helping many countries that they don't have manufacture. This is important that they realize now, but they're trying to catch up this situation. They want to dealing with the speed up the manufacturing the vaccine for the COVID in Indonesia. But I believe that not only biopharma, because the biopharma is the government's company, we should also promote the investor from private, because this is the situations. It's like India, they have some private company too. It means that we should copy the India, how they speed up the industry, especially industry for health and especially for vaccine. Thank you, Pratiki.
Yeah, thank you, Pak Pandu. And I think what you said gives another dimension to the idea of vaccine nationalism. And I think in Indonesia, I have seen, for example, there is some perhaps even political pressure to produce Indonesian vaccine, but I agree with you, that's really not the priority. Use what's already authorized as quickly as possible. Okay, so I'm gonna try and wrap up. I'm gonna go to each one of you for some closing remarks on what you have heard so far, just a short reflection, some final views on vaccine inequity from where you are sitting. Perhaps let me start with Dr. Kang in India. Some final thoughts from you, Dr. Kang, perhaps? Can you switch on your video if possible?
I have a problem. I'm on my phone now because we lost electricity. And
never mind. Go ahead.
But so I think one of the things that we need to understand is that we can't rely on the rich world to provide solutions to us. What's very clear from this discussion is that we are going to need to rely on ourselves and on partnerships to be able to deliver vaccines to all of our populations. And as you pointed out, we contribute over 1/5 of the world's population just with the countries that are discussing this today. So solutions for manufacture, solutions for delivery, solutions for tracking, for safety monitoring. If we share resources and information, we will be able to address things faster. And I think the APIC is a great start to that. Thank you.
Thank you so much for that view, Dr. Kang. Lulu, some final words from you?
Yeah, thank you, Tiki. My very proud moment is to see that now everybody wants to learn about vaccine. Everybody wants to be an infectious disease. Everyone wants to know now what vaccinology is all about. It used to be, they are always taken for granted. And now with the leadership that we are being shown by not just Singapore, but other perhaps richer countries, the collaboration between the rich and the poor countries of the world could actually bring about the end of this pandemic. And truly, it is very important that we are able to produce this coalition through cooperation, collaboration, coordination to effect that change. Okay, Tiki, they're all C. Definitely, we need a change towards the building up of such kind of preparation, because this is not going to be the end. Even if we end this pandemic, there has to be some kind of preparedness for future pandemics. And everybody knows that now. I think every government is now focused on ensuring that we don't experience this kind of unpreparedness before. So to me, this coalition is very important. And so I thank everybody who has been involved in this. And really thank you, Dr. Tiki, for leading this coalition. I am grateful that what Cherry said, we are all in this together. Because just like in vaccinology, what WHO says, vaccines are safe, vaccines are effective. But if we don't work together, we will not achieve what our targets would be and really have to save lives and livelihood, economy. Thank you very much.
Well said, Lulu. Pak Pandu, some final reflections from you.
Okay, thank you. The coalition is mean that collaborations. The collaboration is important because I heard that for dealing with this pandemic, how we to end this pandemic. Everybody want to end this pandemic, but everybody know that no one left behind, because everybody should got the vaccine. It means that how we implement this, we trying to overcome the barrier, overcome in the collaborations, it means within country and also some country in the regions, because Asia Pacific is the most of the populated country that can help to end this pandemic by collaborations. It means that we have wonderful situation now in the global health, not only collaboration, also solidarity, and also share the experience to most of the country have difficulty during delivery of the vaccine. Thank you.
Thank you very much, Pak Pandu. We are just on time. Let me just try to give you some final sort of reflections on from my part based on what I've heard today. So the first reflection I have is, what are the key challenges to achieving equity? And it's around money, it's around supply, and importantly, it's getting it to people. But perhaps for me, as a die-hard vaccinologist, I think the big challenge beyond COVID is to ensure continued confidence in vaccination more broadly. I think Lulu highlighted the risk to the drop in coverage of vaccine-preventable diseases. That's the longer-term challenge. In terms of the various, we've heard that it's around hesitancy, it's around health system constraints, the appearance of variants, which is going to continue in the future, and politicization of vaccine and public health matters. So those are some of the various that I heard today. In terms of way forward, we've heard a lot today, importance of multilateral cooperation and global leadership, the PPR that Mari mentioned, increased donations, not just from rich countries, but from perhaps the middle-income countries. Political will, that has been mentioned, strengthening of our fragile health systems, strategies to overcome misinformation, domestic production, although there are challenges here around regulatory harmonization, indemnity and liability issue, export rules, benefit sharing, etc., etc. And finally, I think the continued importance of monitoring based on data and science. And as the three final comments emphasize, the importance of solidarity, collaboration, perhaps South-to-South collaboration between countries in the region, and trust, for collective action, and as Lulu highlighted, preparedness for future pandemics. So thank you so much to all three panelists. Let me just end with my favorite quote from Martin Luther King. It is not possible to be in favor for justice for some people and not be in favor of justice for all people. So thank you everyone for supporting APIC in this webinar. Have a good day and stay safe, and hope to see you all again sometime. Thank you.